Welcome to week 3 of the nephrology teaching sessions for medical students and residents. Today we're going to be talking about hematuria and proteinuria. The objectives for this session are to be able to differentiate glomerular from non-glomerular hematuria, develop an approach to proteinuria, understand the role of a kidney biopsy, and develop an approach to diagnosing glomerular diseases, which include nephrotic syndrome and nephritic syndrome. So starting off with hematuria, there can be many different sources, starting from the lower urinary tract up towards the kidney. The key here is differentiating glomerular from non-glomerular hematuria. Non-glomerular hematuria manifests as isomorphic red blood cells seen on urine microscopy, shown in the figure below. The sources of this generally include the lower urinary tract. Investigations for non-glomerular hematuria generally include urine cytology for malignancy, imaging of the lower urinary tract, and cystoscopy. Moving on to glomerular hematuria, this manifests as dysmorphic red blood cells seen on urine microscopy, which I'll show you in the next slide. You can think of dysmorphic red blood cells as being red blood cells that are filtered by a potentially damaged glomerulus that are chewed up as they go through the tubules. The definition of glomerular hematuria varies, but is generally at least greater than 2 red blood cells seen on high power field, with at least 5% of them being dysmorphic. This slide goes through the findings that you may see on urine microscopy for a patient who has glomerular hematuria. So as mentioned before, dysmorphic red blood cells are caused by damage to the red blood cells passing through the GBM and osmotic injury passing through the tubule. You can see compared to the previous slide that these red blood cells look far more abnormal, with a few donuts as well as red blood cells having blebs on them. Another finding that you might see are red blood cell casts, which are generated in the small distal convoluted tubules and collecting ducts through precipitation of the TAMS horsefall mucoproteins. This finding is specific but not sensitive. This is a table that highlights the urinary findings that can be helpful in differentiating glomerular from non-glomerular hematuria. So in glomerular hematuria, red cell casts may be present and the red cell morphology is generally dysmorphic. Proteinuria may be present, indicating abnormal glomerular filtration, and clots are generally absent. Glomerular hematuria may be red or coke-colored. Now, extraglomerular hematuria generally will not have red cell casts, and the red cell morphology will be normal. Proteinuria should be absent, and there may be clots, and the color of the blood is generally red. One of the clinical syndromes in nephrology is asymptomatic and isolated glomerular hematuria. The top 3 diagnoses for this syndrome is IgA nephropathy, thin basement membrane disease, and Alport syndrome. I'll talk more about IgA nephropathy later, but in general it has a high prevalence in Asian populations. It also has this phenomenon called synpharyngitic hematuria, where patients develop painless gross hematuria in the setting of an upper respiratory tract infection. Thin basement membrane disease is the most benign disease of the 3 and carries with it no systemic symptoms and a very, very low risk of progressing to end-stage kidney disease. Patients may have a family history of relatives who have hematuria as well, as it is thought to be transmitted in an autosomal dominant fashion. Alport syndrome has the pathophysiology of impaired type 4 collagen in the eyes, ears, and kidneys. The most common form of inheritance is X-linked recessive, and it results in end-stage kidney disease in males, as well as hearing and ocular problems. In the setting of patients who have no impaired renal function, hypertension, or other systemic features, there's not necessarily an urgency to biopsy unless patients are developing progressive complications or if they're being worked up as a potential kidney transplant donor. Moving on to an approach to proteinuria, questions to have in your mind are how much proteinuria, what kind, and where is it coming from? Proteinuria is defined as a urine protein excretion of more than 150 milligrams per day. It can be separated into isolated versus pathologic proteinuria. Isolated proteinuria can be separated into transient or orthostatic proteinuria. Transient or functional proteinuria can be seen when there is an underlying fever, urinary tract infection, or in the setting of exercise, and it generally resolves when the underlying process resolves. Orthostatic proteinuria is seen in young children and young adults, whereby the proteinuria is only present in the upright position. It can be determined by split urine testing, where patients have their urine protein excretion quantified in a supine and upright position. Moving to pathologic proteinuria in the setting of abnormal kidney function, urinary sediment, or imaging, It can be separated into overflow, tubular, and glomerular proteinuria. Overflow proteinuria is generally non-albuminuria and comes from the increased production of low molecular weight proteins such as myeloma light chains or myoglobinuria. It's called overflow because you can think of the protein overproduction overwhelming the glomerulus's filtration barrier. Tubular proteinuria comes from the impaired reabsorption of low molecular weight proteins seen in ATN or AIN and is generally less than 1 gram per day. Glomerular proteinuria is generally high-grade albuminuria, upwards of 1 to 2 grams per day, and comes from disruption of the actual filtration barrier. One of the tests available in nephrology are a kidney biopsy, which is generally done in the setting of diagnostic uncertainty or where there is potential therapeutic implications, such as in the diagnosis of a vasculitis or a lupus nephritis, where immunosuppression is warranted. Kidney biopsies are generally done under ultrasound guidance, and 2 to 3 cores are taken and sent to the lab. There are 3 components to the kidney biopsy, which include light microscopy, immunofluorescence, and electron microscopy. The big risks of a kidney biopsy include bleeding and infection. Contraindications to undergoing a kidney biopsy include small kidneys, given the risk of bleed and the likelihood of just finding chronic scar, active bleeding, severe hypertension, active infection, and coagulopathy. Relative contraindications include a solitary kidney and pregnancy. Now, one of the many diseases in nephrology include glomerular diseases, which are characterized by pathologic alterations in the structure or function of the glomerulus. Now, the glomerulus is a filter between the urinary space and the bloodstream, and where the damage occurs in the filter affects what leaks through. For example, on the epithelial side, podocytes are key in preventing protein leakage, and therefore damaging the podocytes results in proteinuria. Damage to the endothelial side where the capillaries are results in hematuria. Let's now talk about one of the big categories of glomerular diseases, nephrotic syndrome. Nephrotic syndrome is characterized by high-grade proteinuria due to glomerular damage, primarily on the epithelial side of the GBM. I use the acronym PALE to remember the diagnostic criteria. The P stands for proteinuria of greater than 3.5 grams per day, A for hypoalbuminemia, L for dyslipidemia, and E for edema. You'll notice that I have the dyslipidemia in brackets because it's not part of the diagnostic criteria, but instead is a result of nephrotic syndrome, whereby the liver tries to respond to the rapid drop in proteins in the serum by overproducing other proteins as fast as possible, which are cholesterols. Now, the complications of nephrotic syndrome include a hypercoagulable state due to the loss of antithrombin 3 and relative immunosuppression due to the loss of immunoglobulins into the urinary space. Nephrotic syndrome can be categorized into primary and secondary diseases. The primary diseases include minimal change disease, FSGS, or focal segmental glomerular sclerosis, and membranous nephropathy. The secondary causes of nephrotic syndrome result from systemic diseases that cause glomerular damage, including diabetic nephropathy and amyloidosis. Let's talk a little bit more about these diseases. Minimal change disease is the most common nephrotic syndrome in pediatrics, and it's named due to the biopsy findings of minimal change. Light microscopy and immunofluorescence are generally normal, and there's only some podocyte effacement seen on electron microscopy. Now, minimal change disease can be primary or secondary, and when it comes to secondary causes of any of the primary nephrotic syndromes, the big categories include drugs, infections, and malignancies. Drugs that can cause minimal change disease include NSAIDs, lithium, pamidronate, and interferon. Infections include syphilis, Lyme, and TB, and malignancies for minimal change disease are generally hematologic, such as Hodgkin's lymphoma or CLL. The other secondary cause of minimal change disease can be an allergic response to pollen, bee stings, or a vaccine. Treatment for minimal change disease includes blood pressure control and proteinuria reduction using an ACE inhibitor, treating an underlying secondary cause, such as stopping an offending medication if found, and for primary minimal change disease, immunosuppression is generally used, with steroids being first line. FSGS, or focal segmental glomerulosclerosis, is the most common glomerular nephritis in North America. It's characterized by segmental scarring in some of the glomeruli, and the variants are named based off of where the scarring is seen. Light microscopy will show sclerosis in some portions of some, not all, the glomeruli, and immunofluorescence is generally negative, with electron microscopy showing variable podocyte effacement. In terms of the causes of FSGS, these include primary or idiopathic causes as well as genetic causes. This can be from multiple mutations, including nephrin and podocin. Secondary causes of FSGS include drugs such as heroin, pamidronate, NSAIDs, anabolic steroids, and interferon, as well as infections such as HIV and parvovirus. Another secondary cause of FSGS can be a resultant hyperfiltration that leads to scarring of certain glomeruli, and this can be from hypertension, obesity, or a solitary kidney. The treatment for FSGS includes blood pressure control and proteinuria reduction, again with RAS blockade, treating a secondary cause if found, and in primary FSGS, immunosuppression is used with steroids being first line. The last primary disease causing nephrotic syndrome is membranous nephropathy, which is the most common glomerulonephritis globally causing nephrotic syndrome. It is characterized by immune complex deposition in the subepithelial region of the GBM, as well as GBM spikes seen on electron microscopy. Immunofluorescence generally will stain positive for IgG, particularly in primary membranous nephropathy. Membranous nephropathy can again be classified into primary and secondary causes. And for primary membranous nephropathy, in 2009, there was an autoantibody to phospholipase A2 receptor on podocytes that was discovered called PLA2R. There is a strong association between PLA2R positivity and primary membranous nephropathy. Secondary causes of membranous include drugs such as gold, penicillamine, NSAIDs, and anti-TNF agents, infections such as Hep B, more so than hepatitis C and syphilis, and malignancies, with solid organs or adenocarcinomas being more commonly associated with membranous than hematologic cancers. Sarcoidosis and lupus nephritis class 5 also cause membranous nephropathy. The treatment for membranous includes blood pressure control and proteinuria reduction with RAS blockade, treating the secondary cause if found, and immunosuppression in primary or progressive membranous nephropathy. Combination therapy is usually required, which includes steroids and cyclophosphamide, steroids and calcineurin inhibitors, or steroids and rituximab. We'll now move on to systemic causes of nephrotic syndrome, starting with renal amyloidosis, where extracellular amyloid deposition causes glomerular damage. The causes can be primary or AL amyloidosis from an underlying monoclonal gammopathy or secondary AA amyloid from an underlying disease. These can be categorized into inflammatory, infectious, or malignancies. Kidney biopsy will show diffuse deposition of amorphous hyaline material or amyloid on light microscopy with positive Congo red staining with apple green birefringence when light is polarized. For AL amyloid, immunofluorescence will be positive for either lambda or kappa depending on the monoclonal gammopathy, and amyloid fibrils are seen on electron microscopy. The treatment for renal amyloidosis is blood pressure control and proteinuria reduction, chemotherapy for AL amyloid, and treating the underlying disease for AA amyloid. Lastly, we have diabetic nephropathy, which is the most common cause of end-stage kidney disease in the Western world. There are 5 stages of diabetic nephropathy. Stage 1 is called hyperfiltration, which generally lasts 5 years. Patients will have normal blood pressure, normal ultrasound, no proteinuria, and actually an elevated GFR. In stage 2, or microalbuminuria, patients have a normal or elevated GFR, albuminuria of 30 to 300 milligrams per day, and hypertension. In stage 3, or macroalbuminuria lasting 10 to 20 years, patients will start to have a reduced GFR, high-grade albuminuria, and hypertension. In stage 4, or progressive overt nephropathy, patients have reduced GFR, nephrotic range proteinuria, and hypertension. And lastly, stage 5 is end-stage kidney disease, where patients have a GFR of less than 15 and hypertension. Now, the diagnosis of diabetic nephropathy can often be made clinically without a kidney biopsy, especially if retinopathy and neuropathy are present, with there being a 95% association in type 1 diabetes between retinopathy and nephropathy, and 50% association in type 2 diabetes. In patients who do undergo a kidney biopsy, The biopsy will show mesangial expansion, GBM thickening, and nodular glomerular sclerosis from glycosylated product deposition in the kidney. The treatment for diabetic nephropathy includes glycemic control, blood pressure and proteinuria control, and cardiovascular risk reduction. We'll now move on to the second category of glomerular diseases, nephritic syndrome. Nephritic syndrome is characterized by reduced renal function, hypertension, and hematuria. It can be slowly progressive or rapidly progressive, which is a medical emergency. Nephritic syndrome is categorized based on the pattern that is seen on kidney biopsy, separated into linear, posi-immune, and immune complex. Now, when it comes to a rapidly progressive glomerulonephritis, patients are often sent for an urgent kidney biopsy, and you may hear the term a crescentic glomerulonephritis. So, what is a crescent? Crescents are proliferating epithelial cells and macrophages, and a crescent is defined as the presence of at least 2 layers of these cells that are totally filling or partially filling Bowman's space and causing compression of the capillary loops and glomerular space. A crescent is a histologic manifestation of severe glomerular damage and can be categorized into cellular, fibrocellular, or fibrous crescents, with cellular crescents being the most active and fibrous crescents being more scarred and burnt out. One of the diseases that can cause a rapidly progressive nephritic syndrome is anti-GBM disease. This is due to a circulating antibody against type 4 collagen, which is found in the glomerular and alveolar basement membranes. This disease is also called good pastures when there is coincident pulmonary hemorrhage, which can be about 40 to 60% of the time. The disease has a bimodal age distribution and is generally fulminant with a sudden onset with a lower chance of recurrence. 40% of patients may be double positive, where they have a positive ANCA titer and GBM titer. The kidney biopsy in these patients will show segmental GBM breaks, necrosis, and crescents on light microscopy. There is linear IgG staining on immunofluorescence and no deposits on electron microscopy. The treatment for anti-GBM disease is daily plasmapheresis until the GBM titers are negative, pulse steroids, and cyclophosphamide. ANCA-associated vasculitis can also cause a rapidly progressive glomerulonephritis. ANCA-associated vasculitis is caused by a circulating antibody directed against PR3 or MPO antigens in the cytoplasm of neutrophils. It's most common in Caucasian males and has 3 broad clinical subtypes. The first is microscopic polyangiitis, or MPA, which is generally MPO positive. Most patients have renal involvement. Granulomatosis with polyangiitis, or GPA, formerly known as Wegener's, is generally PR3 positive, and most patients have renal as well as airway involvement. GPA patients who are PR3 positive also tend to have a higher risk of disease recurrence. Eosinophilic granulomatosis with polyangiitis, or EGPA, formerly known as Churg-Strauss, can be either MPO or PR3 positive, although MPO positivity is more common, and about 50% of patients have renal involvement, with most patients having airway involvement, including asthma. On kidney biopsy, on light microscopy, you will see segmental GBM breaks, necrosis, crescents, and the disease is termed posi-immune as the immunofluorescence is negative and there are no deposits on electron microscopy. The treatment for ANCA-associated vasculitis is pulse steroids and the use of rituximab or cyclophosphamide. PLEX can be considered in the setting of severe disease, such as pulmonary hemorrhage. The third category of patterns in nephritic syndrome are immune complex diseases, which are categorized by visualizing immune complexes on electron microscopy as well as potential staining on immunofluorescence. The differential diagnoses for immune complex diseases includes IgA nephropathy, lupus nephritis, post-infectious glomerulonephritis, and membranoproliferative glomerulonephritis. One of the ways to differentiate the different immune complex diseases that cause nephritic syndrome is looking at the serum complements. IgA nephropathy is not complement mediated and generally will have a normal C3 and normal C4. IgA is the most common cause of glomerulonephritis in the Asian population and is characterized by the deposition of IgA in the mesangium. IgA can have a range of presentations from isolated hematuria to a rapidly progressive glomerulonephritis. 50% of patients have synpharyngitic hematuria, which refers to recurrent painless gross hematuria in the setting of an upper respiratory tract infection. 40% of patients will have isolated microscopic hematuria, and 10% will present with nephrotic syndrome or an RPGN. Very few patients have IgA vasculitis, a systemic disease with purpuric skin rash, arthritis, and abdominal pain that's usually seen in younger adults and children. IgA nephropathy can be also categorized into primary or secondary causes, and secondary causes of IgA nephropathy include celiac disease, cirrhosis, inflammatory bowel disease, HIV, as well as a number of other autoimmune diseases. Kidney biopsy is characterized by mesangial expansion and hypercellularity on light microscopy, as well as mesangial IgA staining on immunofluorescence and deposits on electron microscopy. The treatment for IgA nephropathy starts with blood pressure control and proteinuria reduction with RAS blockade, and utilizes steroids if there is a decline in GFR, persistent proteinuria of above 1 gram, or if there is evidence of crescentic or necrotizing glomerulonephritis on kidney biopsy. Post-streptococcal GN is characterized by low C3 and normal C4. It's a common cause of glomerulonephritis in pediatrics in developing countries, but can have a bimodal distribution, also being prevalent in adults over the age of 60. It's characterized by the deposition of streptococcal antigens in the GBM, which cause antibody binding. This typically occurs 2 to 3 weeks following an infection with streptococcus, such as strep throat, cellulitis, abscess, or infective endocarditis. In terms of serologies, 70% of patients will be positive for anti-streptolysin O titer, and 90% of patients will be positive for anti-DNase B. Kidney biopsy shows mesangial hypercellularity with endocapillary proliferation and neutrophils on light microscopy, garland-like IgG and C3 staining on immunofluorescence, and hump-like subepithelial and subendothelial deposits on electron microscopy due to the antigen-antibody binding and deposition. In terms of treatment, patients are usually managed with supportive care, as the disease typically spontaneously resolves within 3 to 4 weeks. Membranoproliferative glomerulonephritis, or MPGN, is characterized by a low C4 and normal C3. MPGN is named based on the pattern seen on kidney biopsy, which is characterized by mesangial hypercellularity, endocapillary proliferation, and double contouring of the GBM. There can be multiple etiologies of MPGN, including hepatitis C, more so than hepatitis B, cryoglobulinemia, autoimmune disease, and dysproteinemias. The treatment for MPGN is to find and treat the underlying cause and use RAS blockade for proteinuria reduction. There's now a new classification system for MPGN, which separates it into immune complex only, complement-mediated, such as C3GN or dense deposit disease, or non-complement mediated, such as in thrombotic microangiopathy. As lupus is a complement-mediated disease, lupus nephritis is categorized into an immune complex disease with low C3 and low C4. There are different patterns of injury due to different locations of the immune complex deposition from anti-double-stranded DNA antibodies. There are 6 histopathologic classes of lupus nephritis. Patients with Class 1 and Class 2 lupus nephritis generally only have isolated urinary abnormalities and have minimal mesangial or mesangial proliferative changes on kidney biopsy. Patients with Class 3 or Class 4 lupus generally have nephritic syndrome or rapidly progressive glomerulonephritis. Class 3 lupus nephritis is focal proliferative, and Class 4 is diffuse proliferative. Class 5 lupus, as mentioned earlier, is membranous nephropathy, where patients present with nephrotic syndrome. And Class 6 lupus nephritis is sclerosing, characterized by chronic glomerulonephritis. The kidney biopsy for lupus nephritis is also characterized by a full house immunofluorescence, with positive staining for IgA, IgM, IgG, C3, and C1q. The treatment for lupus nephritis varies on the histopathologic class. Patients with Class 1 and Class 2 lupus nephritis generally don't require any active treatment, whereas patients with Class 3 or Class 4 lupus nephritis generally require immunosuppression with either steroids and MMF or steroids and cyclophosphamide. Class 5 lupus nephritis, or membranous, is generally treated conservatively with blood pressure control and proteinuria reduction with RAS blockade. However, if there is worsening proteinuria or renal function, a renal ultrasound to rule out renal vein thrombus is important, given the risk of venous thromboembolism in nephrotic syndrome, as well as a kidney biopsy to rule out new superimposed Class 3 or Class 4 lupus nephritis, now warranting immunosuppression. Now that we've gone over many of the glomerular diseases, I want to now discuss the different clinical syndromes that exist within nephrology and how you can use your patient assessment to help determine what kind of clinical syndrome your patient has, as this can be helpful in narrowing down your differential diagnosis for what is going on. Isolated urinary abnormalities generally have an insidious onset with hematuria and/or proteinuria, normal renal function, normal blood pressure, and no systemic features. Nephrotic syndrome can have an insidious or acute onset, with generally no hematuria and high-grade proteinuria. Renal function and blood pressure are generally normal, and systemic features include edema, hypoalbuminemia, and dyslipidemia. Nephritic syndrome generally has an acute onset with significant hematuria and proteinuria. A reduction in renal function, a rise in blood pressure, and systemic features can include edema, vasculitis, or features of lupus. An RPGN generally has a very acute onset with significant hematuria and proteinuria, a very rapid and significant decline in kidney function and rise in blood pressure, and systemic features can include vasculitis, lupus, and pulmonary hemorrhage. Chronic glomerulonephritis is more chronic in onset with hematuria and proteinuria present, a slower decline in kidney function, and a rise in blood pressure, and systemic features can include small kidneys on imaging. Let's now end off by going over an approach to a glomerulonephritis. The first step is to assess the urinalysis to identify whether your patient has hematuria, and if so, if it's glomerular or extraglomerular, and if they have proteinuria, and if so, how much and what kind. The next step is trying to identify if your patient fits with a clinical syndrome based on the timing of onset, urinalysis, blood pressure, renal function, and systemic features. Once you've identified what clinical syndrome your patient fits into, you can then propose a differential diagnosis for the pattern of injury that you may see on kidney biopsy and start to potentially identify secondary causes. Now you're all pros at interpreting a urinalysis and diagnosing a glomerulonephritis. I hope you found this talk helpful, and we'll see you at the next session.